Hello and welcome everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, welcomes you to our November 2018 NDUS Presents webinar. Our NDUS PI is Dr. Eric Wish and our NIDA project scientist is Moira O'Brien. Moira O'Brien, I believe, is with us in the audience this afternoon, but unfortunately Dr. Wish was unable to join us as he had a medical emergency to attend to in his family. My name is Erin Artigiani, and I am the co-I for NDUS, and Barbara Kerr, Marvel Al-Nasir, and I will be the facilitators for this webinar. We are all part of the NDUS Coordinating Center team. For those who are interested, you can find detailed information about NDUS, recordings of prior webinars, and invitations to future webinars on our website at www.ndus.org. You will also find instructions on our website for how to join the NDUS network and participate in ongoing discussions with now 1,200 experts and concerned citizens from across the United States and many other countries. We have ongoing discussions on topics including drug policy, epidemiology, and toxicology, and we also now are launching a new discussion area on public health and public safety. So we hope that you will join in and share your thoughts and information and publications with us in our various discussions. We developed the NDUS Presents webinars to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. This month, we are highlighting the Heroin in Transition study conducted by researchers at the University of California, San Francisco. Today, we are very fortunate to be joined by two of those experts, Dr. Dan Ciccarone, the principal investigator of the project and a professor in the Department of Family and Community Medicine, and Dr. Sarah Mars, who is the Qualitative project director for the study. This webinar will be approximately 90 minutes long, and we encourage you to submit questions during and after the presentations. However, please don't raise your hand. Instead, use the Q&A box to submit your questions in writing. And we will hold a brief Q&A session after both our presenters have spoken. Our presenters, Barbara, Marwa, and I will do our best to get to all of your questions, and we will try to address any remaining questions after the webinar. A recording of this webinar and a copy of the presentation will be made available on our website, which again is www.ndus.org, on the page with all of our NDUS Presents webinars. Thank you again for joining us, and we hope that you will enjoy this webinar. Dr. Ciccarone and Dr. Mars, I will turn it over to you now.
Thanks, Erin.
Thank you, Erin. Thank you, NDUS team, for hosting us. I'm proud and excited to be here. Sarah and I are going to present risk and resilience in the U.S. heroin epidemic. It is our summary of 3.5 years of ethnographic research as part of the ongoing Heroin in Transition study. We're joined with a couple of contributors, Jeff O'Doxson and Jason Fessel. Here are our disclosures. In no way do my consulting disclosures have any conflict with the content of this presentation. The Heroin in Transition study is funded by NIH, National Institute of Drug Abuse. We're thankful to our funders. It is a multi-methodological study. It has, our team consists of an economist, an epidemiologist, a mathematical modeler, as well as our qualitative team includes an anthropologist, a historian, and clinician. We are looking on the quantitative side at the big issues, right? What's the 10,000-foot view of how heroin is changing in the country, and what are the specific, what's the geographic and time overlay of medical consequences, particularly focused on overdose, since that is the crisis at hand. As heroin changes, we are seeing an incredible overdose wave hit the country. Now, more specifically, in the qualitative side, we're looking at it. What is the new drug? We treat heroin and new versions of heroin and contaminated heroin, including fentanyl contaminated heroin, as a new drug form. And therefore, how are the using population perceiving this new drug? How are they coping and adapting to it? That's the aim of the qualitative research. We are focusing on the qualitative research in this presentation. I'm going to use the term, we are going to use the term fentanyl loosely to mean all the synthetic opioids, including the fentanyl analogs, other than methadone. I take a lot of photos, my team takes photos. Some of the photos that we present here will be a little disturbing, so just be aware of that. Or maybe a little disturbing. So, for the first time in 2 generations, the US death rate has gone up 2 years in a row. This is despite all the medical, scientific, technological process in our country. And we see here a list of the top 10 leading causes of death. As you would expect, with heart disease and cancer, the 2 leading killers of Americans, they have gone down in mortality risk from 2015 to 2016. If we look at the 3rd place one, this is unintentional injuries. Unintentional injuries has moved from 4th place in this ranking in 2014 to 3rd place. We see a gold bar there. That is the mortality rate for unintentional injuries in 2014. And we see a dramatic increase to 2015 and 2016. Okay, this is what's driving the overall death rate. And as I suspect, when the 2017 data comes along, also showing a rise in death rate, it'll be the first time since the Great Depression that has happened. That data will be in December. What's driving unintentional injury deaths is drug poisoning. Okay, here we see a graph showing the decline in motor vehicle traffic deaths. I don't know about you, but my rather middle class but late model car is telling me on a daily basis what a bad driver I am, telling me to correct someone too far into the right or slow up, speed up, slow down. And so our cars have gotten safer, our laws keep us safe, motor vehicle accidents have come down, but we see a steady increase in drug poisoning over this period of time, such that it passes motor vehicle accidents. So now drug overdoses, deaths due to them, have exceeded those due to car accidents, gun violence, and even HIV at the height of the 1990s HIV epidemic. This is a dated slide of drug overdoses have now passed 70,000 with the more recent data. What's driving drug poisoning deaths is the deaths due to the class of chemicals called opiates. That's why we're all here. This is well recognized at this point. I describe it as a triple wave epidemic. CDC is also using similar terms. First wave of this triple wave epidemic, deaths due to opiate prescription medications, painkillers on this slide, which comes from Julia Lurie and Mother Jones, 2017. Second wave, deaths due to heroin, now passing those due to prescription opioids. That started around 2011 and increasing to date. Now, if we look at CDC provisional data, we'll see that the opioid overdose deaths have started to level off. Heroin is still ahead, but there's a little bit of sort of leveling off there as well. What we don't see a leveling off of is in the 3rd wave. Synthetic opioids, fentanyl analogs, and a few other drugs. These continue to rise. In the epidemiology, we call this an attack curve, this sharp increase in consequences due to an entity. We have a level of 20,000 deaths as of 2016. Provisional data from the CDC, we now have 30,000 deaths due to the synthetics, 50% increase in 1 year. That's the triple wave. Now, there are some differences between the mortality rates, mortality due to opioid overdose and the demographics due to opioid overdose versus the demographics due to heroin overdose. This is not mortality data, this is hospitalization data. We see that opioid overdose is highest in an older group, 50 to 64-year-olds, right? Whereas heroin overdose, higher in a younger age group, 20 to 34-year-olds. And over a crucial period of time here, 2012 to 2014, we see a dramatic increase in young people having overdosed due to heroin. This is during the transition period. This is people who are moving from opioid pill dependency perhaps over to heroin use. and heroin consequences. And we see a similar inverse phenomena happening in the population suffering opiate overdose, a decline over those 3 crucial years in overdoses due to the pills. So this supports this transitioning notion of people switching from dependency on one drug to another drug. But a strong difference in the heroin and fentanyl, the second and third waves of this crisis, is the regionality of it. It is more focused on the Midwest, New England, Mid-Atlantic states, even Florida on this graph, which is looking just at fentanyl and the other synthetics, much more regional than overdose due to opioid pills. And if we were to convert this, this is a counts data, this is not rates. If we would convert this into rates, we would see that California and Texas would be even less lit up as they are here. And smaller states like West Virginia, Kentucky, Tennessee would be much darker. So it's an East Coast phenomena, and I just want us to all be aware of that. Having said that, though, there is notion that this chemically manufactured, illicitly manufactured synthetic opiate, fentanyl and the fentanyl family, is to some degree a worldwide phenomenon. Some of the strongest countries where, other than the United States, Western Canada, heavily hit by synthetics. In Europe, in Finland and Estonia, the heroin markets have largely been replaced by synthetic opioids. And so we stay tuned that as global politics of opium and its distribution continue to change, we're concerned that the synthetics take over. What did we aim to do in the qualitative study within the heroin and transition study? We conducted a hotspot study. We were interested in how, in places where the heroin supply experienced a dramatic change in product, or overdose rates have gone up. So places that were on our radar fairly early on in the grant, maybe even before we got official notice of being funded, were places like Baltimore, places in central to eastern Massachusetts, former industrial mill towns like Lawrence and Lowell. We went to Chicago, Illinois. We went to southern West Virginia, Charleston, Huntington, Nitro, small town in West Virginia, because this is where we thought we would find good material, good stories to explore. Our aims are to understand the lived experience of folks who are using a heroin-like product, okay, and to observe firsthand them using that. Now, we have to remind you all, this is qualitative research, okay? We're not making definitive conclusions here. All of it is observational. All of it is to help generate hypotheses, not just for further investigative study, but also possibilities for intervention. And with that, I'm sorry, how do we do this work? And then I'll hand it over to Dr. Mars. We spend a lot of time with folks. We spend a lot of time in their lived environments, maybe in the streets, maybe in their apartments, maybe in a hotel room, maybe in a dark back alley somewhere. We have a crackerjack entrepreneur, intrepid, that's the word I was looking for, intrepid team who can do this work, including myself. I go out there in the field. We record both audio and video certain situations. We're interested in the micro practices of injection as they relate to risk, and we'll describe a little bit of that in a minute. But we're also particularly interested in what the substance looks like. How do people perceive it? Tell me about this drug, right? How has it changed? What does it taste like? What does it feel like? How do you use it? Do you use it any differently than you used your drugs in the past? Okay, this is how we do our research. Very open-ended, almost naive like questions. Now with that, I will hand it over to Sarah to talk about the results.
Thank you. So our research suggests that rather than users' preferences prompting the addition of fentanyl to street heroin, the presence of fentanyl is a supply-driven phenomenon. And the following observations indicate this. So fentanyl is rarely sold under its own name. Instead, it's sold either as heroin, sometimes as China white, which is an ambiguous term which historically has referred to white heroin from Southeast Asia, or to synthetic substitutes. Sometimes it's made into counterfeit pills, branded, for instance, as OxyContin or Xanax. And these indicate that those responsible for adding the fentanyl to the opioid supply are relying on demand for other drugs to sell it. There's a lack of information and choice for users seeking or trying to avoid fentanyl. And there's a lack of knowledge among sellers at the retail level about what they're selling, whether it's heroin, fentanyl, or a mixture. So Hector, an experienced user dealer in Lawrence, Massachusetts, said, "We're supposedly buying dope that doesn't have any fentanyl in it. But when I started showing up dirty with heroin," meaning his urines were dirty, "I started showing up dirty with fentanyl. When we cut the dope, we don't use fentanyl. The problem was that we were buying the dope already dirty with that, and we didn't know it." Users who've had toxicological testing, such as on arrest or entering treatment, expressed dismay or surprise at finding they'd been unknowingly exposed to fentanyl. With a ground-up influence, we'd expect to encounter slang terms for fentanyl, and yet there's a surprising absence of these. When you talk to heroin users about their experience of heroin, they may have some negative things to say about the complications or the lifestyle that's entailed, but they pretty much universally like the effect of the drug itself. But with fentanyl, it's different. So this is what Tim, a long-term user in Baltimore, said. He says, "Oh, and we've changed all the names for confidentiality. The high is wonderful. It's splendidly wonderful. It's magnified heroin feeling by a great number." But Rebecca and Lowell said, "I don't like the feeling of it. I don't like the high of it. I don't like nothing about fentanyl." And these diverse opinions were pretty common across the different sites. This is some pictures that we took in Baltimore, and I'd like to emphasize that they're not intended to encapsulate everything about these cities, but they're pictures we took in the areas we were doing the research where drug use and dealing is often highly prevalent. So in the top left-hand corner, we have capsules of scramble heroin. It's unusual for current heroin in the US because it's bright white. We rarely have seen this around the country. And it's very similar in appearance to the yellow-topped vials, which are cocaine powder. In the bottom right-hand corner, we've got raw heroin. Unusually, Baltimore has two kinds of heroin on sale, and it's known locally as raw. It's because it's considered to be less adulterated. It's this kind of gray color, but it can also be a brownish color and is sold at a higher unit price. So users reported and our ethnographers observed rapid changes in the appearance and effects of substances sold as heroin, with widely ranging colors, both powder and solution, widely ranging intensity of onset, the rush people talk about, and the effect, a very wide range of duration of action from 45 minutes, which is what you might expect from fentanyl, which pharmaceutically is a short-acting drug, to a very puzzling 12 hours. Even among long-term users with a very high opioid tolerance, they were talking about heroin that was holding them for 12 hours, and this is still something of a mystery. And we found very diverse descriptions of sensations: sleepy, stimulating, similar to cocaine or similar to heroin or other similarities to other drugs, and quite unpredictable. So this is a picture of the traditional heroin that's been sold in the US for a number of decades. On the top left-hand corner, we have black tar heroin originating in Mexico, which still dominates the states to the west of the Mississippi. And it's a sticky, tarry substance that is closer to opium and less refined. And on the right-hand side, we've got the more highly refined Colombian powder heroin, which is typical of the east of the Mississippi. But this has been partially replaced by a Mexican-sourced mimic, also highly refined powder, and they can range in color. So the bottom left-hand corner is a rarely seen white powder heroin from Southeast Asia. It's not around very much anymore. And here you have the scramble heroin again from Baltimore, this unusually bright white heroin with the comparison with the cocaine. And here, something which, although we talk about a wide range of heroin colors that we've seen across the sites, this is maybe, you could say, a more typical color. We used paint swatches to allow users to identify the colors of the heroin that's currently circulating that they've been using recently. And this is somewhere between campfire and sawgrass. So you can see it's not bright white. And then this is a pretty universal color known for a heroin solution around the world. It's kind of Coca-Cola color, you could say, or iced tea. And then here, this yellow tinted liquid that people associated with fentanyl and was photographed in Massachusetts. Here, someone's injecting a milky liquid, which may indicate the undissolved particles, which obviously is hazardous to inject. So this slide shows the diversity of powders and solutions that users identified when we interviewed them across time and across different locations, mainly on the eastern states of the US. And if nothing else, it indicates just at face value the diversity of adulteration that appears to be going on. You've got pale powders on the left and colors of solutions and powders on the right, and then you have these aberrant colors of pink and blue and turquoise at the bottom. And these represent not only a diversity across locations, but also variations within short periods of time people were talking about, with colors changing in a very short space of time. Something that really struck us with many of the people we spoke to was what you could describe as social devastation from the overdose epidemic. Jerry, who'd been in the military and using long-term in Lowell, Massachusetts, said, "Now the dope is fentanyl, and it's killing people left and right. I have over the years, I've watched friends, but on average it was 3 a year. Now the last 3 years, it's been an average of 20. I feel like I'm back in a combat state, and I feel like I'm fighting for my life right now." This awareness of an increased risk of overdose was common across the study sites, but it was particularly intense in Baltimore, Massachusetts, and West Virginia, where we know that the statistics for overdose mortality have been particularly high. Many participants had recently lost friends, relatives, and acquaintances to opioid overdose. So these pictures taken in Chicago, you can see at the top left-hand corner the pink solution that people were associating with fentanyl at the time. A number of people reported that as in circulation in the city. And in the bottom right-hand corner, we have an off-white powder sold as heroin. So what do people do when faced with this uncertainty about what drugs they're actually injecting? So some people used word of mouth, they spoke to other users, and then there were a number of different forms of discernment, a number of methods people used to try to work out the ingredients of their drugs. This is what Scott in Baltimore said. He said, "We all let each other know what's good and what's not good, what we think of the dope and what we think is in it and stuff. None of us know for sure, you know, but we'll say, this is what it feels like. It feels like fentanyl. It looks like fentanyl." And this has got a lot of raw, the grayish heroin you saw in the Baltimore slide in it. You can see the raw, and it holds you a long time. We all talk about that that stuff. Everybody lets everybody know what's good. And in our analysis of the data, we saw an emerging hierarchy of confidence about different forms of discernment, different techniques, and how reliable they might be in indicating what was in the drugs. So the most reliable was considered to be the, what you might call, embodied experience, the feeling of the drug as it enters the body and its continued effect. This, of course, is the most risky way of determining what's in the drugs as well. And then the taste on the tongue was considered slightly less reliable, but still a good indicator, sweet for fentanyl and bitter for heroin. Now, we speculate that the sweetness might be the taste of lactose that's detectable with fentanyl there and not detectable with the bitter taste of heroin dominating. And then the solution color was considered to be more reliable than the powder color. So this is what Kristen in Lowell said. She said, when you add the water to it and pull it back, it's almost like clear. Heroin's dark and brown, it's brown, but fentanyl is like water, kind of like a little bit yellowish. The regular heroin, it can be dark brown or light brown, but it's never yellow like that. If you recall that yellow syringe we saw earlier, is what she's referring to. So what's driving the continuing fentanyl consumption? Well, part of it seems to be the persistent availability. In some locations, users considered fentanyl to be ubiquitous, and they just couldn't avoid it in the heroin supply in the face of their continuing dependence. And another aspect was that with continued use of fentanyl, whether chosen or not, an increased opioid tolerance resulted due to the potency. And so users across multiple sites reported that once they were used to the more potent fentanyl, they couldn't return to using heroin even if it became available because it no longer relieved their withdrawal symptoms. So these are some pictures in Lowell and Lawrence, Massachusetts. So some people we spoke with didn't take any special precautions against overdose, but others did, and they described them to us. These could include sampling small quantities of the drug, seeking feedback from other users, using subsequently to a higher tolerance user who went first and alerted them to the strength of it, and finally naloxone training. So in terms of drug sampling, where people sample a small quantity of the drug prior to taking a larger dose, there were non-injectable routes of administration, such as snorting or smoking or tasting a small amount before the injection. And then there were different methods of injecting a partial dose. There was the slow shot or graduated shot, where the user injected a portion of the solution, stayed in the vein, and then continued or withdrew the syringe. This could take a certain amount of willpower. And then the tester shot, where the solution is divided between two or more separate injections. And this could be challenging for people with limited venous access, which results from extensive use of injectable drugs, and particularly black tar heroin and cocaine, co-injection of cocaine. This is what Liz in Lawrence said. Like, when I get stuff, I don't know what it is. I do a little bit before I do something that I feel. Like, I want to kind of scale out how much I want to do because I don't want to die. But these people are just doing a gram shot and my friend just died 2 days ago. And this really speaks to the proximity of death that we encountered with so many people we spoke to. So Kitty in Charleston talks about doing a tester shot. She was asked, so how long do you wait in between injections? She says, I'll wait like 15 minutes because I'll do one and just make sure it's not too strong and then do the other one. So you do like a little test, and she agreed. And then Ray in Chicago describes an interesting use of snorting to detect the ingredients through taste and feel. So he says, See, when you snort dope, it's supposed to go down your nose and it's supposed to go down smooth. Now, once you get that drain, it's the taste. It tastes like dope. Because see, some dope that tastes like aspirin ain't dope. So once you get all that in perspective, the taste, the smoothness going down, the drain, you'll start feeling a nice warm sensation. So now you know it's straight. And there were other precautionary techniques that people described to us as well. Getting feedback from other users, using heroin from the same batch before deciding on their own dose, using the same batch after a higher tolerance user. Sometimes people would work as running buddies, and the person with more experience would go first and then advise the less experienced user how much to take or whether to go for the full dose. And sometimes these drug sampling techniques were creatively combined together. Someone might get a report from another user and then decide to make up test a shot as well.
Thank you, Sarah. Hi, everyone. So just a transition slide. This is some photos from Charleston and Huntington in southern West Virginia. It really highlights the diversity that Sarah was just talking about. You've got this chunky white powder in the center, which was a bit of a mystery because people liked it, but said it didn't feel like fentanyl, and we were quite curious about what that substance actually was. You've got on the lower right corner, you've got that pinkish stuff that we've seen in a couple of places now. And then on the lower left, with my eye, also something very interesting and a bit unusual, kind of a champagne colored solution. All three of these products were likable as an opiate of some sort. But what I wanted to bring up now, we've been focused a lot on overdose, and rightly so, because there is an overdose crisis going on in the country. But there are things on the horizon other than overdose that relate to the second and third waves of the triple wave crisis. And that is infectious disease, right? We have seen a rise in hepatitis C rates around the country, and we now have not one but two HIV outbreaks that are related to injection drug use. The Scott County, Indiana HIV outbreak, which was related to the injection of crushed and solubilized oxymorphone, brand name Opana. And now we've had one that's related to heroin and fentanyl injection in Lawrence and Lowell, Massachusetts. The CDC was out there this year for an epi-AIDS investigation. Our team was involved in that investigation because we were there prior to the outbreak being investigated, being identified. Also moving forward, we should be concerned about bacterial infections. They carry a high personal cost, but also a high social cost. That includes endocarditis and skin and soft tissue infections. Speaking about the bloodborne viruses, HIV and hepatitis C, what do we think the risks based on what did we observe? What did we report to the CDC as they went to do their epi-aid? We said, well, there's structural risk. And this includes simply not having enough sterile injection equipment access in many of the places that we went to. Housing instability was a very prominent thing in our observations as well. And something that's sort of structural, but one could say that it's also cultural, is this generation gap. And this is really something, this is such a strong theme for me. And I was one of the ethnographers in all these sites, and we're looking at the data now to support what my brain is coming up with, and that is there seems to be a generation gap between the folks that lived through the 1990s HIV epidemic and sort of have their wisdom and their knowledge and their skills, but are not adequately transferring that wisdom, knowledge, and skills to the young folks. Maybe they say the young folks aren't listening to them. Maybe the young folks aren't coming in to access services, as just mentioned, and therefore there's no place to do the transmission of knowledge. But this is something that we've identified, and we're working on a paper now. There are also lots of social and behavioral risks that we have identified, many of which are obvious, but I'll just state them. Sex work, exchange for sex for money or drugs, quite prevalent in all the places that we've been to. There's Cold preparation of drug solutions. This is something that I have written about for most of my career, hypothesizing that, for example, that black tar heroin, prevalent on the West Coast, is protective for HIV simply by the act of it needing 12 to 15 seconds of heating. That kills a lot of the virus, and you can read my papers on that. Greater injection frequency, whether it's fentanyl, which requires a higher injection frequency, may require a higher injection frequency. That's a debatable issue right now. Or cocaine, which is quite prevalent on the East Coast right now. Cheap, high purity, or at least high likable cocaine with its higher injection frequency. This has been shown in prior studies to be an independent predictor for HIV risk. But one of the things that Sarah and I are concerned about is our observations of the staggered partner injection sequence, where the more experienced person goes first to taste, if you will, the chemical for the dyad, right? Does that put the dyad at risk for HIV? Because the more experienced person, having more years of use, might also be at higher risk for HIV going into the relationship. So that's something that requires more investigation. In general, there's a lot of power dynamics that are going on at the dyadic level between partners, whether they're romantic partners or drug use partners. Power dynamics that go by gender, that go by experience, that go by age, that go by income generation. Who has the money? Who owns the drug? Okay, this is something we need to pay attention to moving forward. If this sounds like I'm building up the ideas for another grant, that's true. Also being injected by another person, okay? For example, what we see here. A young man, he's new in his heroin career. He's still afraid of the needle. He still doesn't know what to do. He's having his girlfriend inject him. There's a gendered power dynamic here that needs to be investigated in terms of HIV risk. This is not an uncommon observation at this point. So in summary, what are we seeing? Here are the 6 themes that Sarah presented, and we've published on most of these. The changes in heroin are supply-driven. This is not a demand-driven phenomenon. There are demand-driven elements to it, but that's not the predominant force. There's variation in potency that happens over years, over places, and more intimately, over days to weeks. And the mixtures and the variation is in potency, what drug is the dominant drug in that mixture, and in the mixtures, the fact that there might be multiple potent drugs in there, heroin and a fentanyl or a couple of fentanyl analogs. The devastation is widespread. Our team has to decompress after every site because the pain is real at the individual, social, and cultural levels. There's mixed desirability and some degree of discernment of fentanyl. We came at those questions because we wanted to understand the new drug, but we also want to see if there's any harm reduction message and advice and sort of intervention in there. There are organic precautionary strategies, and I was cynical about these when we first started observing them, thinking they were just reporting what we wanted to hear, but we saw them again and again in different sites, different age groups, people reinventing some of these things that harm reduction had promoted 15 years ago. Okay, and those need to be studied better. Are they good, or are they going to lead to more HIV risk with staggered injections and more frequent injections due to tester shots? There is a generation gap in HIV awareness and practice. This is where we should be focused on going next, both in terms of investigations, but also broader investigations, CDC level investigations, and harm reduction implementations, which I'll talk about just coming up. What do we need? As I move through the next few slides, I'm going from stuff that's really close to the data that we've presented here to stuff that's sort of more opinion-based, or based on my 20 years of experience as a drug researcher, a public health-oriented drug researcher. Okay, so slide 1. We need to better understand the drug supply. We simply can't be waiting, okay, for lagged reports from the DEA and others about what's happening in the drug. People need to know at an intimate level, at a local level, at a regional level, what is going on in the drug supply, and they need to know as close to real time as possible. The reason for this is that the vicissitudes, the changes in the mixtures, in the drugs themselves, in their levels, in their purities, in their potencies, have to be understood if we want to get on top of overdose, okay? It is not just the fact that fentanyl, a 40x heroin product, has entered. Because if a 40x heroin product had entered the stream, and that was the only product, the users would learn to deal with it. The fact that it's changing from one analog to another and back to heroin and then to mixtures, all of different purities and different levels, that is the problem, and we need to understand that better. We need to understand fentanyl is a poisoning crisis. This is not a user demand, culturally driven event. It may become a culturally driven demand event because of dependency issues that Sarah has highlighted. We need broad drug surveillance, and we need to do that not just at the point of a dead body or a collective of dead bodies, but we need to understand it in terms of the drug supply, as I've just mentioned. All right, who needs to know this information? Frontline folks, ER docs, harm reduction folks, and the users themselves need to know this information. And I know we're afraid of it as a society. I've had lots of feedback saying, oh, we can't tell people what's in their drugs because some people will just go flocking toward that. Fentanyl is respected. Fentanyl is feared. Not everybody wants it. I'm not sure why we would make our policies based on just the few who might seek instead of the majority who may want to avoid. The question then becomes not a matter of giving the knowledge so that people can make better choices of what's in the drug supply, but what are the best messaging strategies? And here we turn to Canada, we turn to Europe, because the researchers there have been curious about this for a while, and they're producing literature on how do you message drug supply information so that it gets more benefit and less risk out of it. In lieu of this, people are doing drug checking on their own, okay? So people are getting, by the truckload, shipped around the country, are these little urine immunoassay test strips, okay? Their test characteristics are made for urine testing, not for direct drug testing. People are diluting the drug. They're guessing about how much to dilute the drug, and they're testing. So we don't know how accurate these are. We don't know how useful they are. There are studies coming out that are in the positive that show that people can use them correctly, they can do behavior change. This is an ongoing field, and this is something that we need to stay with. Are there better ways to do drug checking? That's the question that I would ask. A new generation needs HIV hepatitis C risk reduction guidance. I can't emphasize this more, okay? If the HIV epidemic hasn't already started, it'll be starting soon, all right? All the elements are in place for that, okay? We need to gear up both in terms of structural risk reduction, that means needle exchange and other ways to get sterile injection equipment out there, but also behavioral and cultural guidance, okay? We have a new generation who are injecting heroin. Who are they? What is their knowledge? What are their attitudes and beliefs around HIV? Quite likely different than the last time we had a generalized drug injection HIV epidemic, okay? What are the network sizes? The social media and the ways in which people are connecting these days increase or decrease network size? Does it increase or decrease HIV risk? Open questions. And then ultimately, what strategies, what resource provision do we need to do to reduce HIV risk in the places that are very much like Lowell and Lawrence that we'll start seeing rising HIV rates? Okay, and as I've mentioned a couple of times now, do some of these organic sampling techniques that are intended to reduce overdose, will they paradoxically increase HIV? Question that is outstanding right now. We need a crisis response. Stigma remains our biggest enemy. There's been a number of fronts in which this is being addressed. Harm reduction saves lives, is cost effective, and can bridge people into treatment. The Surgeon General is supported naloxone distribution. We need better access to sterile injection supplies, given the size of the growing heroin population out there. And a lot of places are considering supervised consumption facilities. His insight up in Vancouver, well studied, evidence based from this, supports the notion of using supervised consumption spaces in other large cities. But question that Nabarun Dasgupta, Leo Beletsky, and I published in earlier this year in AJPH, an opinion piece. We seem to be focused on supply side response, both in terms of the pill side of the epidemic, as well as the fentanyl side of the epidemic. Okay, this continues to lead to inadequate and even paradoxical results at each wave. We must also address the demand side, which is highlighted in this commentary, the social and economic determinants that are underlying problematic drug use. What do we do if we don't? This is Jalal Burke and colleagues just published in Science less than 2 months ago, showing multiple waves of drug use mortality over a multi-decade period here. Here's the line that emphasizes the current epidemic. Obviously, it's the highest one. It's the most deadly drug wave we've seen in the last few decades. What's coming next? Right behind it, a cocaine and methamphetamine waves. If you put these two together and say there's a stimulant death wave, the mortality rate would compete with the fentanyl mortality rate currently. Now on the right-hand side, the box that says all drugs, they put all these waves together, including a large one, which is unspecified drug that whose mortality we don't identify the drug through. But if you put all that together, what do you get? You get this exponential curve, okay, over, again, a multi-decade, almost 30-year period here, all right? So what happens next is another drug wave. If we don't start to identify what are the root drivers, what are the structural drivers of drug use in America, we need a robust long-term response. This is a project I did with Josh Katz. Sorry, it got blocked out at the bottom there. New York Times earlier this year, we went and did a survey of multiple experts in the field saying, how would you spend $100 billion? What would you, if you had, this fantasy world of a large amount of money, resource, over a 5-year period, actually a 5 or 10-year period, I forgot. How would you spend it? A lot of folks chose treatment, but we're not going to just treat our way out of it. It's an important part, okay? We do need supply reduction. But in the ways that we can block fentanyl from coming into the country, we need to experiment with those and promote those. But we also, and you can see here, the experts wanted a fair amount of money for harm reduction. That's naloxone, that's syringe exchange, that's surveillance strategies, as I've mentioned, and also demand reduction. What is it about our communities that require further development and redevelopment support? Okay, we've showed you a lot of blighted communities in today's photo slides. I'm not trying to make the judgments about the cities, but about the neighborhoods that are there, okay? Community redevelopment is something that I would spend a fair amount of money on in America right now. This is an epidemic of crisis proportion, but it's also a crisis with epic opportunity. The 1990s HIV epidemic came down dramatically because of federal spending and a robust attempt to address the crisis through treatment and prevention. Treatment and prevention can also work in the opioid use crisis. Just to show off a little bit, these are the publications that are coming out of the Heroin and Transition study. These are the qualitative papers that are already out. Here are the quantitative papers that are already out. There are 3 in various stages of review right now. In addition, here are the editorials that I've written, along with one that's coming out from Sarah in addiction, and a book chapter that we've written on our methodology. Here are my acknowledgements, multiple people, multiple places. We're quite indebted to them, and of course our participants. Of course the NDUS folks, thank you for sponsoring this, and to all of you for tuning in today and listening. Thank you all very much, and with that we'll formally end our part of the presentation.
Thank you so much, Dr. Ciccarone and Dr. Mars. That was really a great presentation and far-ranging. You gave us a lot of valuable information about heroin and fentanyl and all of the varieties that are available now. And I'm sure I can tell from the number of questions coming in that this has engendered a lot of thought and discussion among our participants. And so I'm going to switch over to the question and answer session now. And I'm going to start with a question from an attendee who is asking, does the embodied experience about heroin containing fentanyl differ among people who inject the drug compared to people who use other routes of administration?
Well, most of our interviewees were people who were injecting the drugs, so we really focused on that. They They were describing a wide range of different effects, and quite a lot of the long-term users said they could distinguish fentanyl from heroin when they injected it. But we didn't speak to that many people whose main method was snorting or smoking or other methods.
And we did just write a paper called Toots, Tastes, and Tester Shots, where we really explore how people were going through this sort of sampling of strategies that Sarah brought up. The folks who like to do the intranasal prior to injection really believe in it. They really believe that they can discern the fentanyl from the heroin in the back of their nasal passages, in the back of their throat, with a different taste, and also judge its quality. Like, whoa, this is super strong, I'm just going to stick to intranasal, or this is kind of weak, I know what to do with it, I'm going to go and inject the rest. So they would have a decision process after doing their tooting, which is intranasal. Thank you for that question.
All right, thank you. Have you encountered individuals who were attracted to sites of bad batch warnings for a stronger experience, or have your contacts all been repelled by those warnings?
Well, it's interesting because in our previous study, which was heroin price and purity, when we spoke to heroin users then, this was prior to the fentanyl outbreak, people were seeking out the strongest heroin available if they could, because it represented better value for money, and that's what they were seeking. But we found a very different experience with people finding out that there was fentanyl available. Some people were seeking out fentanyl and did want it for the intensity of effect, particularly if they'd become tolerant over a number of years to the effects of heroin. But some people were trying to find out about the availability of fentanyl in order to avoid it, and they didn't want to go anywhere near it. There was plenty of people who said that, yeah. Thanks.
And also the folks on the East Coast that are running the bad batch thing is it happened after we were in Baltimore and the like. So my bottom line on all of this is to do the studies. Let's go and ask the questions. Let's go and do the studies to find out what messages will people respond to, both proactive or positive responses, but also negative responses. But we're seeing, I would say that a lot less people are going to flock. I would hypothesize a lot less people are flocking toward the bad drug because it's simply not what we've observed.
Mm-hmm. Okay, that's interesting. Thank you. How about the dealers? Do they react to fentanyl contamination in their heroin supply at all? Do they take any sort of action or?
Well, we spoke mainly to users rather than dealers, and a lot of users were quite skeptical about whether the dealers actually knew what was in their heroin. Some in the drug they were selling as heroin. Some people said they could rely on particular dealers because they had a consistent product, but we don't know whether that was what was in that product, that they believed it was the same each time. And some people said they did rely on the dealers to warn them that something had fentanyl, or not to to go easy. But that was definitely the minority. In general, we found that people didn't think the dealers knew much about it, and certainly that quote from Hector was not untypical. That he was surprised to find that there was fentanyl in the heroin that he was selling.
You know, I think there's a certain amount of fatalism now too, because the low-level dealers don't have any control over this. It's not they are doling out what they're giving from high up. There's several layers of heroin adulteration and dilution that happen before it gets to the street. Mm-hmm. And each layer gives an opportunity to either add a psychoactive substance or add a non-psychoactive substance like a diluent. But by the time it gets to the street level, these folks don't know. It puts them in a tough bind, because if they want to do the morally right thing, they buy these test strips and do the testing themselves. They're doing that. We've heard, or at least we've heard people are doing that. Or they just sell what they sell, and they face the consequences as well, which include increased penalties across the country now for selling a fentanyl-like substance, which, you know, one could construe as unfair to the street level because, again, they don't know.
Thank you. We have another viewer who was interested in knowing if you have any theories about why there are the differences you were seeing between one market and another in terms of fentanyl being more prevalent in the Northeast, for instance.
Yeah, so that's a great question. Thank you for posing it as theory, because that's exactly what it is. Nobody really knows. I was privileged to go speak at a congressional sub-hearing, and I got to hear the DEA talk about why they think fentanyl is coming from China and where is it routing through and stuff like that. There are two strong theories, which may segue together. One is that fentanyl as a powder goes into powdered heroin. Powdered heroin, traditionally, whether it was Colombian sourced or the New Mexican sourced powder heroin, went east of the Mississippi River. And so the fentanyl sort of adulteration or contamination is going in where the powdered heroin has traditionally been distributed. The other, which you hear from the DEA, they say both, is that it's a cartel decision. That the cartels that sort of own retail distribution, Chicago on eastward, and Chicago is a sort of a major hub for the Sinaloa cartel, for example, has simply decided this. It's a decision, it's a business decision that they are going to now put this additional product in the stream. So those are two that are out there. Everything else, everything that moves beyond that is pure speculation. And even those are somewhat hypothetical at this point.
All right, thank you. Here's a question. Did you ever see a user throw out a dose when they found it had fentanyl in it?
So in our study, we don't use the fentanyl test strips. It's not part of our study. We have observed occasional use of them. There are studies coming out, including one by Nicholas Piper, and I'm on that. It just came out in August on use of fentanyl test strips. There are anecdotal reports of people throwing the stuff out. Also up in Insight in Vancouver, the supervised injection facility, people throwing stuff out. I would say that that's the minority of the minority, though. Most people will simply make, if a positive test, looking at least at the Piper et al. Data, people make positive behavioral choices, which would include diluting it, using it in a different route, for example, intranasal, with the belief that intranasal will have a little less, punch to it, if you will, than intravenous. But mostly, it just gives them a yellow flag to slow down and think about what they're doing, and that's what Piper et al. Observed.
Okay, here's a question from a viewer who asks, has injection drug use been increasing with other drugs besides heroin?
That's a great question. We are overly focused on heroin, and so we don't have a strong opinion about that, but I will say that anecdotally, listening to my harm reduction colleagues around the country, lots of reports about cocaine going up, and the cocaine is either being injected as a solo product or being injected as the classic speedball, as a booster of heroin. A lot of that's going on. Ohio, Pennsylvania. We observed a bit of it in Massachusetts, where cocaine was very popular as well. And the observations of cocaine that we saw was it was being co-injected with heroin.
All right, thank you. We have another query from a user who was interested in the slide you were showing on what's coming next and what you were saying about cocaine and methamphetamine in particular. And she asked, does the graph account for polysubstance use, or were those deaths determined to have only one substance in the toxicology?
So that's the Jalal et al. Paper. I would simply encourage the person to look it up. Science, September 21st, 2018. We do know that it's a difficult thing to do to determine, let's see, can I get I'm sorry, I'm not even sharing this yet. Sorry. Now I think you can all see it. So this is the Jalal et al. Paper, Science, September 21st. If I could do I have a pointer?
We can probably find that article and
okay. So I think
share it on the
distributing
website.
this article, it's a rock star paper article. Obviously, it's in Science. It's getting a lot of press and social media attention. The challenge, of course, is in identifying. I wish I had a pointer. I would show you. Just look at the box under individual drugs. Yeah, they're trying to use the best data to determine what drug. I don't know what they did with overlapping samples. I assume they're relying on coroner reports and already aggregated data. But that's why there's big categories like unspecified narcotic and unspecified drug. And that's because there is a lot of indeterminate values when looking at mortality data. So great question, but I would guide you all to that paper.
Okay, we will make sure we include that. Then here we have a question. In terms of toxicose surveillance, what other methods could be used? Have you considered mass spectrometry?
Yes, of course. So this is where I'd like the field to go right now. I mean, this is something I'm intensely interested in, and that is, can we do closer to real-time surveillance? That could be done at a city level, a county level, a DPH level. There are people who are interested in buying small mass spectrometers for field use, whether it's in a harm reduction program or some other kind of setting. Maybe in the future, supervised consumption space would be a good place for one. They make these small machines now. How useful, how user-friendly they are. All those questions are open right now. Another way we could do it is somehow get street samples off to an official place. The other way to do it would be crime lab data. There's lots of samples sitting around that were collected last week from criminal justice processes that could be tested and a report given. I know Baltimore, I suggested this about 3-4 years ago to Baltimore. I hear Baltimore is moving forward with it. And so I applaud them and other states, other locations that consider this. Thank you for that question.
Okay, thank you. We'll just do a few more questions here. And thank you again to everyone who has been submitting your questions. I know we've gotten a bunch in, so I apologize in advance if we don't get to yours in particular, but feel free to send an invite. Feel free to send your question to us at NDews, and we will make sure that we get back to you if you're still looking for information. So our next question is from a viewer who wants to know a little bit more about what the users you interviewed may have told you about treatment, and in particular, this person is interested in knowing if the users you interviewed in the different sites felt that fentanyl had changed their experience with treatment. For instance, did it change the effectiveness of MAT?
Great question.
Yeah, it's a good question. It's not something that really came up in the interviews. Well, there was one, it did sometimes come up in that people who were using buprenorphine and were sometimes wanting to re-experience an opioid high despite over the buprenorphine, was saying that fentanyl could break through the buprenorphine, whereas heroin couldn't because of its intensity. And sometimes people who said they had been on methadone for a long time, they could still experience the high from what they thought to be fentanyl. But it wasn't something that came up a great deal because ours is not a treatment sample. They are street users who are not necessarily in treatment.
And a lot of these places lack sufficient treatment.
Yeah.
People were desirous of
Yeah.
treatment, including MAT, including buprenorphine and methadone, if they could get it.
Yeah.
Or if they could get back on it, because they'll say something like, you know, I tried it, I liked it, I could be ready again, but now I have to, you know, I have to get back in queue, or I don't know how to do it. We do hear sad stories about treatment access, unfortunately.
Yeah.
Despite this, particularly in some of the resource poor areas that we were in.
Yeah, we had a lot of people saying things like, you know, they didn't have an ID card and so they couldn't get treatment even though they wanted it, or they had insurance at one point and they'd had treatment and now they had no more insurance and could no longer get it. So it was pretty tragic, really. A lot of people who wanted to get off the street drugs and weren't able to.
And also stories, you know, particularly sad stories of people who reported, you know, when coming out of the incarceration setting or even out of a treatment setting, but a non-MAT treatment setting, coming back to the street and overdosing. And so we know that evidence base. And so when we talk about treatment, we need to talk about evidence-based treatment. We need to talk about a treatment that is durable and long-lasting so that people can have somewhat of a sense of protection from the poisoning epidemic that is fentanyl out there.
All right, thank you. So here's a short question from someone who wants to know, of the subjects over age 25, what percentage started their addiction careers with prescription opioids?
Yes, well, this is a qualitative study, and it was it's not a random sample, so we don't gather quantitative data like percentages exactly, but we did see differences in age group and time of initiation into heroin and by location. So in West Virginia, nearly everyone we spoke to had started their opioid use career with pills and then moved on to heroin from pills. In other places, some people were starting with heroin who were more recent users and hadn't ever used pills, and then the slightly longer term ones had used pills and gone on to heroin, and then their predecessors had started with heroin. So there seemed to be a kind of band of time in which people were progressing from pills to heroin in a number of the locations, but in West Virginia it was all pills to heroin. So it's partly a chronological difference and partly a geographical difference.
And then we've written on this, our previous grant, we've written on the opioid pill to heroin transition. In fact, we have some of the earliest papers on that, both quantitatively showing that there's a statistical intertwining of the two epidemics, and also stories led by a paper led by Sarah on people transitioning to heroin from pills. I will say, though, that those papers feel dated to me now, even though they're only a couple of years old, and that is a whole new phenomenon coming up. Young people coming out, maybe they've dabbled in pills, but they're heading to heroin because heroin is the drug right now. And the pills are harder to get, frankly. And so one of the shames about this epidemic is that we don't know the size of the denominator, nor do we know the incidence rate of people entering the injection heroin world. Without knowing that denominator, a lot of our inferences are suspect, right? Because we rely on count data or we rely on rates based on the general population. We do not know the size of the heroin using population. I suspect strongly that it's much larger than any of us think, right? That it is not 500,000 or 1 million or even 1.5 million. It's quite likely double that. And so the sooner the CDC or someone else gets to doing a large demographic study to show how big the heroin using population is, the better off we are. And then we can start talking about percentages of this and proportions of that age group questions.
All right, thank you. Here's a question asking if any of the persons you interviewed mentioned the added burden of fentanyl's association at the mu receptor being relatively brief, and did they talk about needing to inject more frequently?
Great question.
Or anything like that?
Good question, because we really had quite contradictory responses. I mean, there are people who say what they believe to be fentanyl and felt like fentanyl to them was very short acting and they had to use more often. There were other people who said it lasted much longer than heroin and they didn't have to use so often. And then it wasn't always clear, even with some of the people who were talking about it being short-acting, whether they did, in fact, end up injecting more often or whether they just experienced worse withdrawal. A lot of them talked about more severe withdrawal with fentanyl and just used the same in terms of they spent the same but had a different experience. So it's not entirely clear. There are hints that there's more frequent injecting with some people, but quite the contrary as well. So it's a very mixed picture.
Yeah, and I think it's an essential question, and I really appreciate the viewer for bringing it up. One that we really need to know, right? Whether through survey studies or other means, because frequency of injection is an independent risk factor for HIV and hepatitis C transmission. So all the possibilities are out there, right? The fact that fentanyl in some places, let's pick on North Carolina, for example, is becoming the dominant product without a lot of heroin in it, shows that some people there are going to be using more frequently, okay? But a lot of places, the fentanyl comes in as an adulterant of the heroin. So there's still heroin there. So people will say, well, I kind of like that product because I get the extra boost, the extra rush of the fentanyl, but I get the warm, fuzzy legs meaning sort of duration of the heroin. And sometimes it lasts 8, 10, 12 hours, right? So is it a synergistic effect between synthetic plus semi-synthetic? Is it the fact that there's multiple products in there? Is it a fentanyl analog that leads to this long-term? So we have reliable observations of both the short-acting fentanyl only and this long-acting product, which is quite likely a mixture. So I can't say for sure that the whole population is increasing its frequency of injection. It's just not clear, or it's diverse. It's just it's a bell-shaped curve of injection frequencies. There's even people who claim that they're using a fentanyl-only like substance, and they feel that strong rush, and they really like it, okay? And they're okay with still only injecting 3 times a day, even though they don't feel great, you know, 3-4 hours out, because the fentanyl clearly is worn off. But somehow there's something going on that's enough to allow them to just remain a twice-a-day or 3-time-a-day injector. So there's a whole range of responses there that require further investigation.
All right, thank you. We're still getting a number of questions coming in. So thanks again, everybody, for sticking around and sending in your questions. And I do apologize. I know we won't get to all of your questions this afternoon, but you are welcome to submit them to us to NDUS, and we will work with our presenters to get back to you. That would be ndus@umd.edu and ndus@umd.edu, and we will be happy to get back to you after this session. So I'm going to just do a couple more questions here from those who have come in. And we have one here, which is, did you encounter differences related to the drug use between urban and rural areas? And basically, I think they want to know if you know something more in particular about the rural areas and interventions that are going on now.
Well, our research has been focused really in urban areas to date and smaller cities. So we haven't gone out a great deal into the the rural areas, and we would like to do that more. And certainly we got a sense that some of the less metropolitan areas and the smaller cities, there's been a problem accessing syringes and sterile injecting equipment. But the really rural areas, we'd like to do more research into. Is there anything you wanted to add?
Yeah, it's just hard. It's hard to access those populations, particularly with a rapid ethnographic model. I do think that, and I imagine that NIDA is thinking in this direction, that we simply need more ethnographic and qualitative research in this huge epidemic to map out its diversity, like what is going on in rural areas, What little we've observed from folks, for example, in smaller towns like Nitro, West Virginia, and some of these smaller towns in Massachusetts, is a bit of a commuting phenomena. That to me is quite fascinating. That people will go, or they'll send a designated person to either acquire drugs or acquire injection equipment to serve the community. That, of course, also raises the specter of HIV risk, because people going to other places and dealing with the dealing population there run some risk, either whether it's violence or sex for money exchange or other kinds of exchanges. So I should add the commuting risk to our HIV slide, because some places are relatively isolated, and if there's no one there to sort of start the HIV transmission pool, it needs to be introduced. And so that's what the commuting issue raises for me, and that it opens the possibility of HIV being introduced to an otherwise isolated or more rural area. Again, great question, further study.
All right, thank you. Our next question is, did the users you interviewed have any suggestions for harm reduction strategies besides those that are currently being implemented? For instance, any creative community solutions that we might try?
Well, we did encounter people who believed that that a safer injecting facility would be of benefit, so that people could be overseen while they use and don't overdose so much. So that was certainly something that came up.
Yeah, and I think the reason we wrote the Toots, Tastes, and Tester Shops paper is to show that there are organic, reinvented solutions that people are interested in. And just because we found a subsample of our folks that were interested in doing that, we weren't surveying them. So just the fact that it comes up in our ethnographic work means that it's quite viable and maybe even reasonably prevalent in the community. In fact, I'd go as far as saying that it's not unfeasible that the fact that some of the leveling off in this epidemic isn't due to cultural adaptations to the drug stream as it is. The other things that we hear out in the community are people want to be kept safer. They want to know what's in the drug stream, which is why when they hear about the fentanyl test strips, they try to get them. They want to know, for example, from us, why we're not distributing them. So they want to know what's in their drug. They want to know how to make a safer decision about it. There's lots of stuff that happens that's at the harm reduction, and I just like to call it organic. It sort of happens out there in the community, in the streets, that harm reduction should pay attention to. But then when you go back and talk to the harm reduction leaders, and I'm one of them, I've been in the community for 20 years, they'll say, well, we don't have enough resources, or boy, that's an interesting population, I'd love to get to them. And the Harm Reduction Coalition, for example, has done a lot of consultation with small town and rural areas, including West Virginia. I know because I attended those meetings where they're doing sort of technical assistance. I would like to see it more of a dialogue, which I think is what's suggested in this question, and that is, what does the community need and want, and what is it that, not necessarily the Harm Reduction Coalition, but this idea of public health safety, what could public health safety do based on community input? We tend to infantilize users as being somehow, not with it enough to listen or to be part of a conversation, and that is simply not true. They would love to be part of a conversation. They attend harm reduction conferences and meetings. They're very vocal, very opinionated, and if we listen to them, they will quite likely not only be safer, but we have the opportunity then, and also with their opinion leaders, have the opportunity to change the direction of the generation that's entering heroin use right now. And that would include the spectrum all the way to treatment. It's not that harm reduction exists in one camp and treatment in another camp. This is a continuum. Harm reduction bridges the continuum between the out-of-treatment street or rural drug user and the in-treatment folks. And so this is the kind of conversation we need to have, and I would strongly support it.
All right, very good. Thank you. So I'm keeping track of the time, and I think unfortunately we're going to have to start wrapping things up now. I know we still have a number of questions here, so I'm just going to do a couple of more. And the first is from our colleagues to the north, and they have said that in Western Canada, we have seen large differences in the purity of fentanyl that generally range from 1 to 20%. We also see 100-fold differences in fentanyl concentrations in fentanyl-related deaths. Do you think that the differences in perception of drug effects or duration are related to dose?
That one is the question that gets the I don't know answer.
Okay.
That's exactly what we need to study. Because if we studied that in the States, and kudos for doing that up in Western Canada, that's exactly what we need to do, then that just opens up a whole nother set of questions, and that is, what do people perceive when they're injecting acetylfentanyl at 3x heroin versus injecting fentanyl at 40x heroin? Can they perceive that difference? What happens when the fentanyl comes in at one dose versus a dose 10 times higher? Don't know the answers to those questions now, and that's exactly what we need to know given the diversity of this poisoning epidemic.
All right, so keeping for one more question with this topic of overdoses, we have another viewer who wanted to know if the individuals you interviewed talked to you at all about overdoses, their experiences or others, and if they talked about the characteristics of those overdoses and how they may have changed as the products available changed and fentanyl became more involved.
Yes, no, well, people did talk about fentanyl and being a faster onset of overdose, that sometimes that it would happen before they could respond. It was a quicker effect, and yeah, there's been some great work by John Zabel on this in Massachusetts, and looking at the sudden effect of fentanyl on breathing, and sometimes on creating this kind of rigid chest and inability to breathe, and so on. So yes, we have heard a difference between the impact of an overdose from perceived heroin versus perceived fentanyl.
All right, well, thanks again. Thank you to both of you, Dr. Ciccarone and Dr. Mars, and thank you to everybody who joined us for the webinar today as well. We really appreciate your presentation and sticking with us through all of the questions, and thanks again to all of you who submitted questions today. And I know we didn't get to all of them, and so just as a reminder, while we ask you to do a brief poll here, which I am launching now, and tell us a little bit about how you felt about this webinar and what you'd like to hear about in future presentations. But again, if we didn't get to your question, or you have some additional thoughts or questions that you'd like to share, you're welcome to email us at nnews@umd.edu, and we will work with our presenters to get back to you. And we will also take another look through the questions that have come in as well. And also, just to let you know, we do have 2 webinars coming up in the new year. This one will likely be our last for 2018, but coming up in January 2019 on the 9th, we will be joined by Dr. Michelle Peace, and she will be presenting on her research that's focused on using e-cigarettes and other technologies to vape illicit drugs. So we hope you will be able to join us then. And she will be followed by our colleagues at the DEA Special Testing Lab, who will be doing not just their regular annual update on what they're seeing in terms of NPS, but also some new information that they've been collecting and reviewing on methamphetamine as well. So I think you will find both of those to be quite useful. And so keep an eye on the network, because we will post announcements as we get closer to those dates for those webinars. And just let you know that we will put a full recording of today's webinar along with the slides from the presentation on our website, www.ndews.org. So if there's anything you want to go back and check or look at again, you'll be able to do that. Just give us a few days to get everything up there. And so thanks again, everyone, for joining us. Looks like there are a few still answering questions. Yep. And so I think that's about it for today. So thank you, everyone, and I will end the polling, and we look forward to seeing you again next time.